The numbers are slowing down now. I think I might kick us off. People are still joining, but we've only got an hour and we've got a lot to get through, so I think we'll probably kick off if that's okay with everybody. Good morning. Thank you so much for joining us this morning. My name is Victoria Thomas. I'm Head of Public Involvement at NICE. And we're delighted that you're able to join us this morning to discuss implementing shared decision making, putting the NICE guidance into practice. This webinar is being recorded and will be available on NICE's YouTube channel after the fact. Closed captions is available if you want to use them. If you just click the CC button at the bottom of the screen to activate it. They transcribe as we speak, so they're not always 100% accurate, but if you need that enhancement, then please do take advantage of it. We'll be doing a Q&A with the panel at the end of this session rather than after each presentation. And if you have questions for the panel, if you could use the Q&A function rather than the chat function. I believe the chat function has been switched off. So if you have questions, please put them in there. We will answer as many as we can. Those that we can't get to, we will theme and answer after the fact. So we will send them the responses to all participants afterwards. At the end of the session, you'll be diverted to a short survey. We'd be very grateful if you could complete this. So we have some points of quality improvement that we can take on for future sessions. So that's it in terms of the housekeeping. The aim of today is to highlight the benefits of shared decision making to systems and organizations and introduce resources for increasing its implementation. And we've got a range of speakers from within NICE and from within NHS England and the health service itself to talk about how this might work. So I'll be setting the context from a patient perspective at the beginning, and then handing off to Alf Collins from NHS England and NHS Improvement. My colleague Andy will outline the guideline itself, and then Debbie and Becky will take us through what it's actually like on the ground. And then we'll come back to Andy to think about the kind of practical tools for putting things into practice. And then we'll have the Q&A session. So by the end of this session, our aim is that you as participants should be able to explain and describe what SDM is and what it isn't, evaluate the potential organisational and system benefits from a wider uptake of SDM, assess what the possible barriers and facilitators might be to implementing shared decision making in your local organisations, and think about formulating a plan for next steps to increase the implementation of shared decision making within your organisations and systems. So quite a few learning objectives, but we'll see what we can do. And I hope you all have a really enjoyable and interesting morning. And we're very, very pleased that you're able to join us. Laura, could I have the first slide, please? So unfortunately, the patient speakers that we had lined up weren't able to join us this morning, but we have some quotes from them that I really think are an excellent contextual starting point for us in our conversation this morning. So if I could have the next slide, please, Laura. So Sian is a patient and community leader in Wales. She sat on the committee that wrote our guideline on shared decision making. And she wrote this fantastic blog about her experience of being on that committee and the kind of benefits that she saw coming out of what the recommendations stated. And I've just highlighted a few of the words that she used that seemed really resonant for me. So it's about making SDM the norm rather than the exception. It's about promoting patient leadership and transforming that relationship between doctor and patient or practitioner and patient. It's about this reaching agreement on appropriate treatments according to people's values and priorities. It's a way of making sure people have informed choices. and that actually people's experience of the process of care as well as the outcome of care is really, really important, and people can feel kind of positive about that. Again, this idea of bringing in patient leadership at board or senior management level within an organization is a really powerful message about mainstreaming this into services. And then she's just, again, for her, highlighted the key kind of words that summarize what's important around shared decision making. So empowerment, choice, trust, respect, ownership, confidence, equality. And I love this quote that she says as part of her blog. It's about identifying what matters to you rather than what's the matter with you. If I could have the next slide, please, Laura. And Carol Pitt-Keithley was also another one of our patient members of our committee. And she has highlighted a really interesting quote, and I won't read it out in full because we will make sure that you have access to the slides afterwards, so you'll have an opportunity to read this in more detail. But she's really clear that while she's the expert in what matters to her and what she values and how whatever's wrong with her affects her, she isn't the expert in the treatment options or all the ways that she can help herself. So the idea of shared decision making isn't about handing off the decision to the patient. It is about partnership. It is about truly understanding risks and benefits and reaching that kind of joint conclusion. But also this really important point, I think, for me, is having the clinician understand how much and to what extent the patient wishes to be involved in that kind of decision making. And she again has this really nice analogy about talking to mechanics about what's wrong with our cars and what needs to be put right and what will happen if we don't take any action. And isn't our health and well-being more, or at least as important as our cars? And so for her, shared decision making is a no-brainer, because if we can talk to our mechanics, we ought to be able to talk to our doctors and our other healthcare practitioners. So from that patient perspective, this is something that for many people is wanted and desired, and very much represents a kind of a shift in the relationship between patients or people with lived experience and their clinicians and other practitioners. And we really hope that the recommendations in the NICE guideline are providing the system with a mechanism to make that happen in practice. But that's very much what the purpose of today is about. So with that in mind, I'm going to hand over to Alf Collins from NHS England and NHS Improvement. Alf is the Clinical Director for Personalised Care. Have I got that right, Alf?
That's exactly right.
So over to you, Alf, to give us the policy context in which all of this sits.
Thank you so much, Victoria. What the amazing quotes. They were just so pithy, and we need to rise to that challenge, right? In NHS England, we have to support the system to rise to that challenge that we've been given. How can we ensure that we do truly, as health and care professionals, work in partnership with people to have conversations about what matters to them, as well as, you know, what is the matter with them? It's about that synthesis, that coming together. Next slide, please. So I'm Alf Collins. I'm Clinical Director for Personalised Care. Personalised care is a coming together of the concepts that sit under the person-centred care kind of umbrella. Shared decision-making, support for self-management, health literacy, social prescribing, and the concepts that sit under the personalisation banner. So personal health budgets, personalised care and support planning, and choice. We brought them together in NHS England as a kind of a tangible, as well as a kind of a symbolic coming together of health and social care. I'm not going to go through this slide in enormous detail, but what this slide represents is the various concepts that sit under personalised care. We talk about 6 components: shared decision-making, support for self-management, personalised care and support planning, choice, social prescribing, and personal health budgets. And I tell you what, I always reel them out in a different order every time. For those of you who don't know about our stuff, do look up Universal Personalised Care, and there's our policy document that came out 3 years ago. Next slide, please. So shared decision making is one of the core components. We think of it as essentially an entry point into universal personalised care, the model of care. It's where the conversations begin to support people with regard to their care, support or treatment options. And again, I'm not going to go through this slide in enormous detail, but what we know is in order to implement, we're going to be talking more about implementation through the next hour, we need to do something about preparing the public, or individual patients, to have these conversations. We need to do something about training teams in motivational interviewing and risk communication. We need to do something about making sure the system is supportive. So, there are tools available in the workflows. There's leadership at every level to support shared decision-making to actually take place. And we need to make sure, of course, that there are some commission services. Part of the shared decision-making conversation may well be about, so you've got knee pain, the choices right now are a walking group, or physio, or tablets, which is the right way forward for you, or what matters to you. Of course, it's all very well talking about a walking group, but if you don't have access to a walking group, you probably won't talk about it. So we think about those 4 chunks of stuff that you need to do in NHS England in order to really make sure that you can have high quality shared decision-making conversations and processes. Next slide, please. And this is my last slide. I just want to give you an overview of where we are. Stuff only runs nationally and centrally if you can hook a number of priorities together. So shared decision making is a priority, elective care is a priority, maternity is a priority, and prescribing, especially with the recent publication of the National Overprescribing Review, is another priority. There are a number of other priorities, but we've elected within NHS England to really push with shared decision-making around shared decision-making regarding the elective care programme, in particular with regard to the really high volume procedures like MSK. And some of you will know that the Versus Arthritis team have already put out some really good tools for 4 MSK conditions. And of course, NICE has got loads and loads of really good decision support tools, patient decision aids available on its website. We're also working with the Winton Centre in Cambridge to do a little more around MSK. We're working with them to develop some PDAs, or we're calling them DSTs, decision support tools to support the conversation between healthcare professionals and patients at the point of care. And also EBI, the Evidence-Based Interventions Programme. The Evidence-Based Interventions Programme, if you don't know about it, is looking at low-value procedures. Not no-value procedures, but low-value procedures. So we think it's particularly important that patients share decisions before they undertake or undergo or have a low-value procedure. So that's elective care. The maternity programme, there's a lot of stuff written about maternity, the Ockenden review. There's the second Ockenden review about to come out, and it's pushing us very hard and absolutely appropriately to make sure that we've got great tools in place to support women to make great choices across their pregnancy, labour and postnatal journey. And lastly, prescribing. As I've said, there's the National Overprescribing Review. We're working with the pharmacy teams in NHS England and CPP, the Centre for Pharmacy Postgraduate Education. I always get it wrong, to promote training there. But also the Personalised Care Institute has got some great training on its website, as has NICE. So lots of stuff going on. I wanted to just give you a brief run through the national policy context. I'm going to hand back to you, Victoria, and I'm sadly going to have to leave. Thank you, Victoria.
Thank you, Alf. No, that's really fantastic, and I think it's really interesting to look at those priority areas, because actually, given that Sian had made that point about equity and equality, there's a lot of inequality and health inequality in these particular areas. So I think it's really interesting that those 2 areas are combining. As you're having to leave us, unfortunately, would you be, if there are questions that are directed at you, are you happy for us to pass those on to you?
Yes, of course, Victoria, of course.
Okay, that's fantastic. Thank you so much for joining us, Alf. I really appreciate you taking the time, and I look forward to seeing you soon. Thank you very much.
Bye.
So the next session that we have, I'm going to hand over to my colleague Andy Hutchinson, who is a senior medicines advisor here at NICE, about our shared decision-making guideline, which we published last summer. So over to you, Andy.
Thanks very much. Yes, so I'm a pharmacist in the medicines team here, and I was involved in the quality assurance from the NICE perspective of how the guideline was put together. So I'm going to give a quick canter through it. It's not a long read, but there's some stuff well worth reading in there, and really connecting back to what some of our patient members of the guideline committee there that Victoria quoted. It's about making shared decision making part of everyday life, everyday care. To making it the way we do things around here. That's where we're hoping to get to. And some of us are old enough to remember when clinical governance was a thing, and there will be chapters in policy documents titled clinical governance. And now we don't have that anymore, because clinical governance just runs through everything. And where we want to get to is shared decision making being the same kind of thing. So there are recommendations in 4 chunks, which so about embedding shared decision making at an organizational level, putting it into practice, and then there's some smaller stuff about patient decision aids, and some specific stuff about how to communicate risks and benefits. And of course, this links back to Alf, what Alf was talking about, the supportive systems, prepared patients and trained teams. You could almost think it was planned, couldn't you? Anyway, so high-level leadership. I'm going to focus particularly in this webinar on the stuff that's about the organizational aspects. We've got another webinar next week where we will be looking more at what does this mean for healthcare professionals, sort of in those individual encounters with patients and service users. So, but from a high-level leadership, it talks about making a senior leader accountable and responsible for this, and that's at board level. Excuse me. Board level or equivalent. And also the guideline says do this at every organization or system, regardless of size. So someone in a GP practice needs to be thinking about this, someone in a CCG or a trust needs to be thinking about this, and someone at ICS level. It also talks about appointing a patient director to work with that senior leader. It's a consider, a think about, rather than a please do this thing. And the only reason the committee said that really was because there was a realization that having said you need to do this at organizations of every level, for very small organizations, it just might not be feasible to actually appoint a director, a patient director to do this. But nonetheless, the direction of travel is having patient service users involved at every level in the systematic planning of this. The guideline says that you need healthcare professionals as organization-wide champions, and also, guess what, service users as well as champions. You need a plan. You fail to plan to fail. You need a plan. So it's about identifying good practice that can be shared, identifying people that can become service SDM trainers, and that's again clinical staff and patient service users. Think about how you're going to involve people who use services in supporting that implementation. And of course, you need to monitor what you're doing somehow to know how far you've come and where you need to go. So there's a section on what needs to go into support for healthcare professionals in terms of their skills and competencies, and it talks about making sure that this is something that runs through all continuing professional development, train the trainer style workshops, and also making sure that the training is practical as well as just theoretical. There's value in having some kind of theoretical framework to this, but you really need to be able to practice and try this out. It can't purely be classroom, sort of theoretically based. And later on, we'll talk about some resources around that. It's really important to promote shared decision making to people who use services. So this is the prepared patients part. How are you going to do that? Well, it's not easy, of course. It's not something you could do overnight, but it's relatively straightforward to do. You can think about using posters and other media to support this. Really get that message across that it's okay to ask. Are they okay to ask these kind of questions? What are my options? What are the pros and cons? And how can we work together to make a decision that's right for me? And I don't want them to say, oh, it's dead easy, no problem at all. But it's something that we could perhaps start to think about working on. Moving on, if we can. Yeah. So as I said, the guideline has got some detailed information about how to do shared decision making in that consultation, before, during, and after a discussion. And discussion is the word the guideline uses to talk about any kind of interaction between healthcare professional and service user, patient, where you're going to make a decision. I'm not going to go into that now, but there's some great stuff there. I think, yeah, oh yeah, that's right. So there's some small information about patient decision aids and kind of making sure that people have got access to quality assured patient decision aids. Patient decision aids can be a really helpful part of the toolkit, but they don't replace the skills of and the attitudes towards shared decision making. And finally, there's some good practice recommendations about how we communicate risks and benefits and consequences. And following from that, as a sort of plug for another sort of resource, we've got a whole framework that talks about how you can develop decision support tools, which will be covered in another future webinar date to be confirmed. But there's a whole packet. What I want to emphasize here is we're trying to come at this from a number of different directions to support the service. We know the service is under a lot of pressure. How can we help get this really established? So I'll shut up now, and I'm going to pass on to back to Victoria, but then on some people who are really doing this in real life. Thanks very much.
Brilliant. Thank you, Andy. And I think one of the really great things about this guideline and why it's very different from a lot of other NICE guidelines is that we started from the position that shared decision making was the right thing to do, and we looked for evidence about how to do it well. And I think that's why it's really different. This wasn't testing whether it was good or not. It was assuming that it was, and then thinking about, we knew the evidence that it was good. So how could we support the system to do it well? So now I'm delighted to pass over to our colleagues, Debbie Draper, who is a Senior Personalised Care Manager at Nottinghamshire CCG, and Rebecca Barker, Becky, who is a consultant anaesthetist at Sherwood Forest Hospital, which sounds incredibly glamorous and very much like Robin Hood. But anyway, I'm sure it's not like that on the ground. But anyway, Debbie and Becky are going to take us through shared decision making, the new normal, what this actually looks like in practice, rather than the kind of the NICE and policy decisions. So Debbie and Becky, over to you.
Okay, thanks, Victoria. Yeah, it's really good to be here. Becky, I don't know if you could put your camera on, but I'm going to start by talking about kind of what we did at a system level. I've been involved in shared decision making since 2018, and we've done a lot of work as a system to try and embed shared decision making. And Becky's going to come in and talk more about how and what she's done locally at Sherwood Forest, but we're very much joined together on our approaches and what we're trying to achieve. And Becky's certainly one of my key champions in this work, which is one of the things that you highlighted in your NICE guidance. That is a necessity to help achieve what we're looking at doing here. So I'm going to talk you through our journey in Nottingham and Nottinghamshire, highlighting some key things that we've done locally and try and pull out the challenges and then how we've overcome them to help you guys think about how you can embed it in your systems. So Nottingham and Nottinghamshire, we were a demonstrator site for the universal personalised care model that Alf referred to earlier before it had been embedded into the long-term plan. We were testing it out. So fortunately, we did have additional support and input from NHS England, and we kicked off with a event with Alf Collins. He came down to support it, and 3 people from NHS England supported us to review where we were now, think about what we wanted to achieve within shared decision making. As MSK back then, as is now, was a priority, it was agreed we would focus in MSK, and it was agreed that we would focus on the triage element of the pathway of MSK. So worked with the physio teams. So you'll have seen your GP, you're referred into physio, where you have the triage and start to have the conversation about what's happening for you and what can we do to support you, and whether to then go on to surgery, if that is indeed the right option for people. So we had a really fantastic group of people. So thinking again about your champions, the physios, we had clinical leads, so they were the leaders of all the organisations involved in the MSK triage work across the system, which there's several, and we worked together. NHS England does have a really good tool as a self-assessment to help teams, rather than thinking, oh, assuming this is what we need to focus on. The graphic that Alf shared with the 4 chunks is extremely helpful. I always go back to that chunk, where are we at with these things? And the self-assessment that NHS England created helps you to focus on. If you try and go at all 4 chunks, you're not going to be able to get where you need to. There is a huge amount behind making it happen and work that needs to be done. So the self-assessment just helps teams focus in on, well, where are we now? Are we doing this? One of the challenges that may be familiar to you is, oh, we do all this already. Oh, we're really good at this, but are we really? How do we know that? What feedback are we getting from the public on that? So the areas that we decided to focus on were preparing the public was key, really, really important, supporting the workforce, training them. We can't expect our workforce to kind of take this different discussion approach, perhaps that for some people is maybe contrary to how they've been trained historically. So that was an essential component, and decision support tools. So we embarked on our journey. It's Okay to Ask is a brand that Stoke developed, and they kindly agreed for us to take their branding as long as we gave them the credit, quite rightly. So we branded It's Okay to Ask for Nottingham and Nottinghamshire, and did what you described. So we printed out loads of postcards with the 3 questions that you talked about earlier on the back, and put posters up. Of course, then COVID hit, and I think it's really challenged us to rethink, because no one's going into the offices, meeting rooms, surgery to see the posters on the wall. But anyway, that postcard was sent out with every appointment to help prepare public to have the different conversation. I'll come back to that, because there's a reason that Prepared Public is back on our roadmap. It's not a one-off piece of work. It's a journey, and there's always more to do. Is one of the things I'd say. Supporting the workforce. So we decided motivational interviewing was the right approach for the teams. They identified what training they felt they needed, and we purchased training from a company called Et al. To do that work. And absolutely, it wasn't, these are the facts, this is about shared decision making. They ran fantastic events, training days that were very much about role play, getting involved, doing the doing, and actually feeling what it was like to be at the other side of the different conversation and discussion. So we had really positive feedback on that. And then the other thing we embarked on, which was a huge piece of work and very challenging, was to develop decision support tools. We developed 13 in the end. We were very ambitious, and it was challenging. It's really challenging to get a group of clinicians to sit down and write something that's health literate, because they all want to pull back to using the medical terminology and words, and you get it to a point. So it all went through SMOG. We ensured it was health literate. It was being through the SMOG readability test, and then you'd present it back to the group and they'd like, oh no, but we don't use that language, we say this. And I'm like, no, you're not allowed to change it. It's simple language, it's for the person. And absolutely, they're just tools to support the conversation. It's not, here, have this nice leaflet about your options, and no discussion takes place. All these things are kind of the building blocks of bringing it all together. I'm not going to show the film, but we do have a film that we made of NHS England at the end of this work, back before the pandemic, personalised care in Nottinghamshire. So you're welcome to look at that. And the people involved in the work on the film talking about what they did, why it was so important, and the push to focus on what matters to you within the work being core. Senior leadership was key, making sure we've got senior leaders helping to drive this work. And moving forward now, as we come out of the pandemic, having nice guidance, we're really pleased, because I think it helps drive it and give it more gravity and push. We've now got shared decision making, personalised care very much in the long-term plan. And all those policies, directives help us to push it forward on the ground. And where we're now moving to, as Becky's got involved, we're now rebooting the MSK group, and cancer are involved as well. We started to do some work in elective recovery just over a year ago, and focusing in on that priority area of elective recovery. How can we truly embed personalised care into the recovery and the people that have been waiting over 2 years for operations, you know, and really embed a personalised care approach and shared decision making being key to that. And also what I always felt was early on, we did just take a chunk of the pathway, like the triage chunk, and now we're really opening up and saying, look, this should be embedded. System transformation should just be, this should be part of everything we do. And how do we make that happen? It's not an add-on afterwards. Transformation should be shared decision making. We're very good, aren't we, in the NHS at focusing in on pathways, and oh, we've got to do this, and if we make the pathway amazing, and we'll make it so slick and it'll all be perfect for the people. But that doesn't always mean that people are heard and seen in that. So shared decision making is a key part of what we need to do. So I think if you move the slides on, yeah, and challenging the culture, I mean, I'm not going to lie, it's really challenging. It is challenging to deliver this change, and Becky will say the same. And that's why you need your champions to keep each other going. Co-production, we're doing much more co-production, proactive work now with public, which is why we're moving into preparing the public again. We're working with Patient Information Forum and the Patients Association. They had some funding and they're working with us to develop our tools to prepare the public for this different conversation. And that's been quite challenging for us and uncomfortable, because we think we're doing the right thing, and actually they're saying, no, we don't like this, this isn't very good, we're not going to fill this in, what on earth's this all about? So it's fantastic, but it can feel a bit, you know, uncomfortable, I suppose, but that's what we need to do, and we're all committed to it as a group. So we've got a fantastic group of people. Shall we move to the next? Oh yeah, still a long way to go. Yeah, we set a goal and vision. Do you want to go to the next slide, Laura? So I won't talk to this because I've talked to you about it already, but I thought as slides are going to be shared already afterwards, it gives you a bit more context and information. So what we're doing now with It's Okay to Ask is I am working with comms to think about how we have a campaign moving forward. Obviously, we've been competing with all the messaging around COVID, but I really want to look at how we do get this It's Okay to Ask out as a marketing comms campaign. And PIF and Patients Association are working with us those tools to actually reframe all our letters and paperwork, so that the letter that goes out with the appointment doesn't just say, oh, here's the hospital, this is how you get here, take a bus, or, you know, it actually starts to prepare people and sets up, think about what you want to get out of the appointment. And that's being co-produced with a group of people. The other key tool that they're working on is the letter that goes out to people after a consultation. So we realised that's key, because at the moment a lot of clinicians write the letter to the GP with huge amounts of medical terminology in that me as a member of the public wouldn't understand, and maybe the GP doesn't understand either, to be fair. But so they're looking at having supporting and working with us to have a standardized letter, and the letter is actually going to be written to the person who the discussion and consultation was about, and copied to the GP as it should be. So I think that's another really exciting and good opportunity to help us shift. And then the system needs to support us, like you say, senior leaders, to say, this is the standard and this is what we're going to do here and not. So was there any more slides? Again, I've just put these on the slide so people have the context, but I've talked it through. Supporting the workforce, yeah. Talked about that. Really positive feedback from that training, from all the staff, 100%. And decision support tools, yeah, they were based around BRAN. What are the benefits, risks, alternatives, and absolutely, what if I do nothing? So is that my last one, and over to Becky? Yeah, over to you, Becky.
Thank you, Debbie. From a clinical perspective, I think I've been on a bit of a journey with shared decision making with all these things, and been in my own little bubble to begin with. I'm an anaesthetist by background, so the sort of patients that I see are within the high risk clinic, where we're having quite complex conversations about whether or not to have surgery. But also I've done the pre-op leads role, so I've looked at the patient pathway. And what strikes me, and what we've tried to do, is to look at all those touch points that the patient has, from going to see the GP with the initial problem all the way through to solution and going back to the GP. And there's so many different interfaces, and recognizing the importance for a patient of consistency of messaging, so the GP almost being helpful with priming. So you've got a problem with your knee, but in the context of you, in the context of your heart problems, your lung problems, how will that work? They'll have a look at that, but it's going to be in the framework of that. You might want to ask them about this. So you might want to ask them about how you're going to manage any rehab, and really not sort of guiding the patient to think about the whole lot. And then that we have those similar conversations, particularly with high risk patients, along the pathway. But also looking at the patient as an individual and personalising their care, that we can then actually do things proactively early at all those touch points to optimise and improve them. And we've done a lot of work around shared decision making and supporting patients in terms of getting them a bit fitter for surgery as part of their elective recovery and optimisation, which is also really high up on the agenda. So next slide, please. We've got really, really good as healthcare professionals of speeding our patients through their pathways, of going, you've got a 2-week wait referral with RTT, with cancer patient pathways particularly, you go to see your GP and very quickly you're on that pathway train, and your destination is predetermined. And each step of the way is very logical, that you go and you have, sorry, I've lost this slide. So each part of the pathway is very logical. It leads on to the next bit of the pathway in a coordinated way, and that we've smoothed out all the kinks in the journey. We've got really good, but what happens is that the patient just gets on that, and there's no way of getting off. So if I give you an example that I saw, is a fairly frail lady in her mid-80s with lots of comorbidities, who had a daughter who was in her 60s, but with learning additional requirements and mental health needs. She was her carer for her daughter in her 60s, and her daughter had been quite upset that she wasn't as quick as she used to be, and this lady who was in her 80s said she felt tired, so she went to see a GP. Because she was feeling tired and fatigable, they did a full blood count which showed she was anemic. So she was referred in along the 2-week wait pathway, had a colonoscopy, had a cancer, was consented for surgery, and came to see me in clinic. By the time she got to see me in clinic, and I sort of talked through, and we went through the risk benefit, and actually asked her what did she want. She was asymptomatic from this cancer, and what she really wanted was some meals on wheels and a bit of extra support so she could stay at home and look after her daughter, she was terrified of the prospect of needing rehab and not being able to get back home, and it wasn't what she wanted. But she'd been through this really slick, impressive process, but we hadn't asked the right questions, and we hadn't put those things into the context of that person. And it really made me think about, how do we make sure that we have those conversations and not just treat the disease process, but we treat the patient that's attached to that, both their comorbidities, but also their social circumstances and things that are important to them. Can I have the next slide, please? Oh, have the slides gone? They've gone for me. So the next slide I was going to have, I can't see the slides. So the next slide that I got was about 2 patients who both had bowel cancer, both elderly patients in their with similar comorbidities and frail. And one of them decided that she wanted to have an operation, that and one of them didn't. And the reasons being that one lady had she had a really good quality of life. She'd been found to have on routine sort of national screening for bowel cancer, had a potential bowel cancer, had a colonoscopy, found to have a cancer, but she had a really good quality of life. She knew she was frail and towards the end of her years, but she was but she had granddaughters who took her out. It took it in turns to take her out to the garden centre for lunch, and she loved that, and she didn't want to lose that, and she just wanted to sort of keep going. The other lady had a cancer whereby she had terrible symptoms. She said she got no quality of life at all, that she couldn't leave the house because of risk of sort of soiling herself, and so she just wanted something doing and needed something doing. So 2 very similar patients with same pathology, same operation, but because of how it impacted them and their quality of life, who chose to have an operation and not to have an operation. And I think sometimes we're as clinicians, we have to say that that's okay. It's okay not to want an operation. And that's something that's quite hard for people to actually go, you might not want, I think sometimes we think we can fix you. We can fix this problem. You have this problem, we can fix it. And actually going, it's okay. We don't have to fix you. That actually fixing you is letting you spend the rest of your days how you want to with your family. Next slide, please. And this was shown earlier, and I think it's really important. Because it's what we go back to, as Debbie said, that the ask 3 questions in the prepared public. I've learned so much by engaging with the population. Some of the things that I think that I'm achieving, that whether my intentions are good, that I'm maybe not quite hitting the mark that the public want, or getting my message across in the way that I think I am. So by early patient engagement, I think would be, from my learning, a really important and willingness to listen. That the it's okay to ask, and the framing of the letters of how we send things out to patients, priming them to come in and go, what are my options? That I want to know the benefits, the risks, the alternatives. What's the natural disease process if I choose not to have anything, and how is it relevant to me? I think as clinicians, when patients come in, empowering them to be able to ask those questions, and us feeling not judged to be able to ask those, is important. On a point of the letters, I've changed how I write my letters. My letters now, I write very much to the patients in the format of about them. A lot of the things that I do as perioperative are around whether or not someone should have an operation, whether or not we'd resuscitate them, whether or not that they would be should have sort of CPR respect forms before they go for surgery, all of which is really important. But also it's important that they have that information in black and white, that they can talk to their families with, and in language that they understand. And I think that's really important. Having had friends who send me letters where they've, I had a friend who's she sent me a letter saying, I've had this, I've got a new baby, they're not feeding, I've got a letter that says they've got a murmur, a grade 3 systolic murmur at the apex, and I've been referred to for an urgent cardiac ultrasound. I'm terrified. What do I do? And actually she needed just a bit of reassurance that they were dotting the I's, crossing the T's, but all the signs of the fact that they said they're feeding well and the growth centiles and all this sort of thing meant that it was, that was reassuring signs. But she didn't see that. She just saw those bits because of how the level of jargon and the inaccessibility of that letter. Sorry, next slide, please. So when we look at the systems that we've put in place, absolutely right. Role modeling. I've been sort of as a champion giving talks within our organisation, and I know that NUH within the ICS have had external talks as well, coming in about shared decision making and the importance. And the importance of actually the role modelling from the leaders within the ICS and within the trusts to sort of put this on the agenda as being important. And also, and I think that it's not going to change overnight from my experience, but slowly picking away at it. I see more and more letters that come to me now with this patient could have an operation or they shouldn't have an operation. These are their operative options, and we can look at this together. And the way I say shared decision making is it's like a layers, that each professional that comes in contact with that patient adds a little layer of detail to aid to help the patient come to that end decision, which is there around what they need. I think using the Brown and using the Brown framework for our letters is really important, and monitoring the patient feedback, it again is really important, and communication between teams. Next slide, please. So training the teams, we've got everyone loves a bit of free CPD. So I've been sort of championing the 1 hour free CPD to put in your appraisal. Happy days. There's a lot of discussion about whether it should be mandatory. It's not for us at the moment, but certainly other things about focusing on what good is. So a lot of the time when I do this, I talk about, I've given 2 examples here where things, with the lady where things didn't go quite so well, but there are other things whereby patients have had really good outcomes and there've been really positive interactions between different teams. And I think celebrating those within an organisation is just as important as showing when things aren't as good as we might like. And these stories are shared within ours from our organisation, from the very top sort of downwards. And we've been working with other organisations. So yeah, next slide, please. I'll hurry on to the end. I've talked about patient letters. There are now sequins around shared decision making, which is another thing they're using to sort of prompt organisations of the importance of these changes and reasons to change, and using different sort of resources to collaborate how we're doing. And a lot of that is, again, looking at patients and how we get qualitative and quantitative feedback. So I think it's the last slide. Debbie, I don't know if you want to do the key messages or if you want me to do it.
Yeah, no, you can do it.
Okay, so I think that it's been a real pleasure for Debbie and I to be invited today, and I think what we wanted to get across was about the co-production. I think we've got a really good relationship between Debbie and I and the other people who work within the personalisation, which is absolutely key, that we're all in the same direction and we are a tribe. We've tried to focus on the patients, and the more that we do, we think we're doing it, and then we do a bit more and we realise we need to do that even more, and not just on the pathways but on the system as a whole, and that embedding shared decision makes it within all the transformation programs, so that it's across all. It's almost an essential bit of everything that we do, is putting that personalisation into it, and that we believe in it. Having a tribe means that you have days when it's difficult, because it is hard work getting people to change culturally, and to drive this, but it takes determination to succeed. But I think we've got a really strong set of champions, and that's what's enabled us to get this far, and hopefully we'll get even further in the future. Thank you.
Thank you so much, Becky and Debbie. That was so enthusing, and kind of it just really brings it home kind of what it means in practice. And I love this idea of finding your tribe as well as finding your champions, and I think that's always really, really important within an organization, to find the fellow travelers who think the way that you think, and I think that's really, really important. I'm very conscious of time, so Andy, I'm going to ask you to do your presentation in record time, so we have a time for a few questions at the end. But like I said, we will collate all of the questions that you've asked and make sure that we send you a proper response to them, because I can see there's quite a lot, and thank you very much for your participation. But Andy, over to you, and I'm sorry to rush you.
No, that's fine. Okay, so Debbie and Becky have already spoken about the NHS England sort of summary guide checklist kind of thing, which is brilliant, really well worth looking at. This is the NHS England improvement resources are really good. The website is there and you can look at those. In terms of guidance, in terms of measurement, I just highlight these 2 things in particular: Collaborate and SDM Q9. Collaborate is so easy, it's just 3 questions. I mean, academics will argue about the relative merits of these two tools, but just 3 questions. And I know there's an MSK service in the Northwest that uses this routinely to evaluate how good their shared decision-making conversations are. So that's great. SDM Q9 and QDoc are a bit more detailed. Sorry, move on, Laura, there we are. Again, links from the NHS England website there to lots of stuff around schools for health. There's the schools for health, there's the other training there that's available. Health literacy, Debbie mentioned the importance of health literacy. It's just key, and there's some training there. Move on. Thanks. We've talked about Bran and asked 3 questions a lot, and there's people have helpfully put stuff in the Q&A, some other links. Bran is just so good and such an easy mnemonic. I used it with a cat when I used it with a vet when I took the cat to see them the other day. It's just brilliant. Move on. And finally, I'd really encourage you to look at this. This is a training package that, well, several of us on this call and colleagues at Keele have put together to support the guideline. It's 6 interactive modules, bite-sized chunks. It's free to access. You don't need to register or anything like that. The link is straight from our website there. Best of all, you've got virtual patients to practice your skills. So it's as practical as it can be for e-learning. There's an MSK module and a statins module. It doesn't matter if that's not your area of practice. My daughter's a midwifery student. She did, you can see an image there of Dennis, the guy coming to ask about his statins. She could still do it, even though she didn't know the therapeutics of statins. It's not relevant. And being computers, they don't get bored, they don't get tired, they don't get offended, and you can't actually kill people by making the wrong recommendations. So I'm going to shut up there and move on to the important bit, which is the Q&A. Thanks very much.
Thank you so much, Andy, for that whistle-stop tour through the tools. It's one of the reasons why it's really important that we will share the slides with you afterwards, so that you can access those links directly. And obviously, because we're recording this, you can revisit some of that at your leisure. Laura, who's been brilliantly managing the slides, you have some questions for us, I believe, that have gone into the Q&A. Is there something you'd like us to start with, or other points that people want to raise? Laura, over to you.
Yeah, I love what's like I say, we'll give people collated answers to these afterwards, but there's a question in here that said, I'd be interested to hear if the training helped people see the reasons why people aren't doing SDM, such as feeling more vulnerable, less in control and out of their comfort zone, so that they feel these things, they know how to acknowledge them. I wonder if that's something that, Becky, you want to share.
Yeah, so I think a lot, it's absolutely that, isn't it? Is that we're so used to, as clinicians, going, this is the problem, this is the answer. It does. And often patients come in expecting that, in terms of their, it's sort of very passive. Being a patient is a very passive thing, that you come in and you are told, this is what's wrong with me. This is, you're going to get fixed. And I think that's sort of preparing the public to actually, that's probably not what we're aiming for. We want you to make a decision that's right for you, and that all decisions are different. People make different decisions. I think it is very different for clinicians. I think I work a lot with surgeons, and I know that from a surgical perspective, that idea of being in control of, this is a problem, I can fix this problem, is consciously much easier to manage. However, when it's not always the right thing for the patient when you put it in the context. I think the resources out there are really good, and there is some from within CPOC as well, the Centre of Perioperative Care, that's the Peter's Journey and things that are really good to get people thinking and get people understanding about where we're coming from with shared decision making, and that it's not about making you vulnerable. Actually, it's about showing your workings, about how you've got with a patient to the answer. There's a lot of worry sometimes that if there is a way of solving the problem, or particularly with, and I do surgery, so a lot of this is an operative solution, that if we are able to do that, but then we don't do it, there is a, medical legally, we're not doing the right thing, or there is a consequences for not doing that. But actually writing down, and I do this on my own anaesthetic charts quite regularly. I've spoken to the patient, this is the risks. You can have a spinal, you can have a general anaesthetic, we cannot do the operation, you can wait a bit, and here's the risks and benefits of each in like a tree diagram. I have that documented so that if anyone goes back, you can see exactly how we've got to the decision of what we've got to. And actually, that's a really nice, safe way of doing it. And it's a real conscious way of doing it, that actually we've got to that decision together, but we've just talked through it and documented how we've talked through it. But the resources out there are really good, I would say.
That's really good to hear. And I think it was really interesting that somebody put a comment in reference to something else said about women making good decisions about maternity services. Actually, women should be making their decisions about maternity services. And I think it's really important that we can reassure clinicians that actually patients are able to make what they might think is the wrong decision from their point of view, but it is their decision and therefore it is valid. So I think that's really, really important.
And I think sometimes we have a tendency to go, are you sure? Are you sure you're sure? Are you sure you're sure you're sure? And you know, and from a personal point of view, that's happened with a family member of mine in their respect form, end of life. And you get into that sort of arena of actually, we've made this decision, you know, it is in their best interest, but you as clinicians, you want to extend life. Well, they don't want that. And it's like, you've got to let people make their decision for them. And it's not about us just going, our ambition is to make life longer. And that's it. Some people might want that. Some people might go, actually, I want my quality of life. That's what I'm most interested in. And we need to allow for that.
Absolutely. Laura, I think we've already got time for another couple of questions. I'm really sorry that we don't have more time. It just feels, I didn't realise people would have so many questions, but Laura, over to you.
I've got a question here for Debbie. So question says, I really enjoyed your presentation. Please may I ask, have you gathered outcome data contrasting the difference before and after embedding shared decision making? Co-designing care makes perfect sense on so many levels, but I'd really like some evidence to share. Thank you.
So probably not as well as we should. We are using the Collaborate tool locally, but that was part of the work we did to implement Collaborate, to find out if we are doing this, if again getting that instant feedback from people about whether they had a good quality shared decision making conversation. So I don't have data before. However, the work that myself and Becky are involved in now, and we had a meeting yesterday, is to look at how we evaluate the impact of the work that we're continuing to take forward in implementing shared decision making, continuing to improve the preparing the public and doing more training. So we are working on how we measure the outcomes, the impact of what we've achieved there. So sorry, not quite.
And your honesty is very welcome, but it's always the way, isn't it? How are you measuring it? That's what everyone always asks.
And I think personalised care is always a really challenging area to measure. How do you know it was that and not this? But certainly, again, I suppose that's a shift in the system that we've got the work and support now from the system analytics team to help us to shape and demonstrate that moving forward with the work that we're embarking on.
And to, you know, accept that qualitative things are as valid as quantitative things, and you know, that's really important. One more quick question, I think, Laura, and then we're going to have to wrap it up.
We've got lots of people asking if they could be connected with Becky and Debbie, so we can follow up on. But I think this one for Victoria, I think this one probably your field here. Okay. Someone said, very interesting to hear about patient engagement. How is NICE suggesting the system engages relatives, carers, and the wider public to create the culture shift needed? Society has been indoctrinated by governments and industry that medical advances and technology are good for healthcare. How can we change this narrative at population level?
That's a really, really good question, and possibly I'm able to answer it. I think we've talked a lot this morning about shifts. I think we've talked a lot about kind of we haven't used the power word, but actually all this is about a shift in power as well as a shift in decision making. It's about acknowledging that that people are partners in their care, and our former chairman David Haslam always used to say, whose body is it anyway? And I think that's for me that's the really important thing. And I think it really goes back to how we train clinicians and how we I mean, Andy's an educator, he may want to come in on this, but it's about how we train people who are very kind of often very alpha type personalities, often very, very kind of, no offense, Becky, but often people who go into medicine have that very kind of want to make decisions, want to be very, very kind of pro kind of the positive action side of things, and actually building in something that's more reflective and more kind of thinking about ambiguity and uncertainty and what that might mean in practice, I think is really, really important. And I know clinicians really struggle with uncertainty, but that's actually at the heart of shared decision making. It's about how you make decisions that may be, you know, very binary in a very kind of in a very difficult area. Becky, do you want to come in on that just finally?
Yeah, no, I just want to say that I think you're absolutely right, and it's a conversation that we've had, and I've next week got a meeting with the medical school to talk exactly about that, because I recognise that as being a key point. There was a really interesting talk where they in some medical schools they go and they spend a week with a dementia patients and work with a family with autism and to see what it's like to live with that. And I think I'd like to try and talk about how we teach medical students to actually go out and watch the decisions and how you make a decision and do almost a shared decision making essay, if you like, with a patient making a complex decision. Because I think you're absolutely right. We've got to, it's hard work changing the people who have already in depth in practice, and whatever they're teaching the next generation, you're not going to get the change. So I think we've just got to get in there and go, actually, this here. And if you look at societal macro changes about what's important to people in terms of well-being and compared to how it was 20 years ago, I think that's definitely a way into those changes. It is actually sort of getting people at that entry level.
Yeah, brilliant. Thank you. Andy, did you want to come in very quickly?
I think we've got limited time, but I just think there's an important distinction between complicated problems and complex problems. We want a surgeon, for example, to be technically absolutely brilliant at doing that operation. That's a complicated problem that you can practice at and get really, really brilliant at, or at least is performing as absolutely superb, spinal or whatever. The complex problem, which is much more difficult, is whether you should be doing that surgery or not, or if there's something, a better alternative. And that's hard. That's hard. The other thing is guidelines, not tramlines. NICE is, they're guidelines. They describe what care should be like for most people most of the time. They are not rules to follow slavishly without thinking.
Indeed.
There we are.
But we hope what they do is provide you with a framework to be able to say, actually, the evidence tells us this is what works, so let's try it. And let's try it within, always when people talk about the kind of the N of one trial, let's try it with you. Let's see what happens, what might work for you. I'm very sorry that we've gone over time, and I'm very grateful to those of you who are still on the call. I know a couple of people have had to drop off. Thank you so much for attending this morning. Thank you so much to the speakers. I thought, you all did such a brilliant job, and really, really thoughtful and considered presentations, and really, particularly Debbie and Becky, grounding us in what this is like kind of at the coalface, and thank you so much for that. I'm hugely grateful. Thank you so much to those of you who've attended. As I said at the beginning, you'll be prompted to complete a kind of evaluation as you leave the video conference, so please do that, so that the next time we do one of these we can make it even better. But I would just like to take this opportunity to thank you all, thank the speakers, thank my colleagues who've kind of run the back end of this system and done it so brilliantly. I hope this has been a good morning for you. Please do get in touch and let us know about your thoughts on it, and let's hope we can work together in the future. Thank you all very much indeed.